Okay, so let's talk about how to keep your ER from slipping. So I do a lot of improvement work with ERs. I'm sure you've gathered that. And one of the most heartbreaking things is to put so much energy, excitement, enthusiasm into improvements and then to see it backslide. And what you need to know is that improvement work is continuous. Things change. You have to adapt. And so there's some very specific things that I think that you can and should do to hold on to your gains. Anybody got a successful improvement project under the belt in the last 2 years? Yeah? And are you holding on to it? Yeah. It takes quite a bit of effort, and maintenance is really important. So I'm just going to throw out what I think are 5 parts to holding on to the gains and keeping your ER from slipping. And here they're going to be, and I'm going to run through them in more detail. Engaged leadership, that's very important. Periodic cleanup, and I'll tell you what I think that should look like. Metric-driven management, you should live and breathe by your numbers. Then you heard me talk this morning, and I'm sorry if I'm beating that drum, but I think people need to come to work and understand what the expectation is for them. For instance, I think that somebody showing up to work in the fast track should know roughly how many patients are they hoping I'm going to see, and how quickly am I supposed to see them. Any other place you go to work, you know what's expected of you. And I find that most ERs is, say, well, how many people will you see in the mid-track today? Meh, right? That's the answer, meh. So having goals for productivity and efficiency, and then copycat behaviors, and I'll show you what I mean by that. So engaged leadership. This is a heartbreaking story told in numbers. So you can see the metrics, and by now you're getting used to them. Door to doc, length of stay overall, length of stay admitted, so forth. And you see, I periodically give you the benchmarks as we have them. These happen to be AAEM 2016 and EDBA 2016. Hospital A, look before their project started. Door to doc was more than an hour. Their waiting room was a bit like a horror show. There was one guy limping with bloody bandages hanging off of his leg, and another lady was throwing up in a garbage can, and the abject misery quotient was stunning. In any case, you can see where they were, and they weren't happy with where they were. Look at Hospital A, 2016, 100 days after go live, with a change package like we've been talking about so far. And you can see everything improved. Door to doc, 23 minutes. And by the way, I just want to point out to you, if you are using eyes on as your door to doc time or door to provider time, that is absolutely not what CMS is wanting you to be doing, and you're not measuring it right. Okay, and mind you, I see this. It was stunning. I'm at an ER, and the nurse is doing triage, and there was an APP sitting over here on a stool with a cow, and eavesdropped on the patient, clicked scene, eyes on, and ordered a couple things. You understand that has no value from the point of view of the patient. And that's not what we mean. I'm talking about when we talk door to doc, we mean a true encounter with the patient. It can be brief, it can be very focused, but it's an actual provider-patient encounter and the commencement of care. So if you're cheating, you can run, but you can't hide. Someone's going to catch up to you, and that's just not the way that is measured. But in any case, look how well they did. They shortened that door to doc time, which if there's one metric you should pay attention to, it's that one. It correlates with patient satisfaction, with complaints, with walkaways. That time to see the provider is probably the most critical time. There's all kinds of forgiveness when that happens in a timely fashion. And so again, you can see that they improved. They asked me to come back. Let's take a look at what happened. This was the 100 days before when I went back for a checkup in 2018. And where are we? In most things, we're actually worse than when we started. And this is heartbreaking because I will tell you what, it's much harder to come back from that kind of recidivism than to start from scratch. That's going to be a heavier lift than the first time when we did it. So I would implore you, if you've had some good success, do everything in your power to hold on to it, and don't figure that you're done. We're not done. It's an ongoing project. Any of you using Tableau in your ED? Are you? Excellent, excellent. It's my favorite platform. You know, there's lots of visual displays of information. And now in the ER, you don't just need a dashboard. You need a visual display that shows you what's going on. What I like about this is you can set the times, and as you can see, the green and even yellow-green, that's really good performance. The top is their temperature gauge on door-to-dock. It has EMS arrivals, walk-in arrivals, and overall. And you can see they're going green. It's very green. They're keeping to their goals. They said they wanted the patient seen by a provider in under 30 minutes. Look at how we fell, and if you look closely, it's much more dramatic than you may be thinking at first blush. Look at that bottom line. Look how much red there is. That's patients waiting more than an hour to be seen. So you can see they have slid back. They are in quite a bit of trouble. Mind you, we knew when we were done with the project, we had not fixed the midnight to 5 a.m. We knew that was troublesome, and we were still trying some different things to work on that. But you can see it completely slid, and this was heartbreaking. What went wrong? They had their chairman, who'd been there for 10 years, who was intensely interested in flow and metrics and so forth, left. They had an interim chair who, quite frankly, I don't think cared. Right? And mind you, understand, people have different interests, especially this is an academic center. They had their research interests and their teaching interests and so forth. Operations took a back burner, and they slid. So if you want your docs to care about it, you have to care about it. If you want your nurses to care about it, you nurse leaders have to care about it and show that in every way. And I think there are certain characteristics that make a really good leader. I have hopes for this department because they've gotten a new chair, and maybe they'll get themselves back on track. All right, clean up your department. What do I mean by that? So there are things that if you were going to start from scratch, you would design for your department and you would carefully articulate. And what happens is over time, these things slide. You have turnover. New staff doesn't know what the rules are or how we do things. Maybe your ESI breakdown has changed. Maybe you're boarding and you weren't before. I mean, circumstances change and you need to adapt, and I think it's worth revisiting. Maybe you just sit down with your council or leadership team or whoever does operations at your shop and go through all these things, validate that they are still working for you, and then do some major education. Take a week or two, have some in-services, and educate everybody so they know. And people, you may find some surprise. Oh, I didn't know we weren't supposed to send patients on Coumadin to the fast track. I didn't know, no one told me that. And those are the kind of things that kind of come up in a cleanup. Your patient streaming, maybe it needs to change. Maybe it doesn't work for you anymore. And I'm going to fly through these again, I know I want you to get used to sort of seeing them and thinking about them. And I'm going to answer somebody's question this morning. I've given it more thought. So when do you need a fast track? When do you need doc and triage? I don't think anybody knows because, to be honest with you, there's so many variables that figure into it. But I would suggest to you that by 24,000, you need a place for low acuity. And whether that's going to look like a fast track, an RTU, whatever. By 28 to 32,000 visits, you're starting to think, gee, it would be really nice if we had a doc out here seeing people quickly. And you might want the doc and triage, but you're torn. Do I want that or I want to keep my fast track? You may start to see now you have certain days or certain months where you want to add that physician triage. I think anybody that does operations would agree, as you get close to 40,000, a physician in triage is the way to go in today's world where we don't have enough capacity. These are just rough numbers. Of course, things like acuity breakdown, of course, things like unionized nurses and nurse ratios. I mean, there's a lot that can sort of figure into this, but those are some rough guidelines. And oh, by the way, you know that all of us now are over 40,000 visits pretty much. That's the average ER. So we're all crossing that barrier to where we're going to want these different patient streams. All right, here's showing you, so you start treating people with minor injuries one little place in the ER. Now your volume's gone up. You're actually going to dedicate space, and if you're smart, you're going to dedicate a person. So by the way, ERs that have a fast track with no dedicated provider do much worse than ERs that have fast track with a dedicated provider. All right, this model is emerging for pediatric ERs and lower acuity breakdown ERs where you just have a rapid treatment unit. It's a fast track plus. It's anybody that doesn't need to lay down, and we could possibly discharge from the front without putting them back in a bed. Okay, then, like I said, you're going to start thinking about this by 32,000, I'm sure. Do I need a physician in triage? And you may start with everything but 1s and 2s going through there, like I said this morning. You may want to do it this way. If you've got a very strong, high-functioning APP, just send the fast track to the fast track. Do these models make sense to you, basically? And, is it time, how many of you, as you hear this, think, maybe we should go back and revisit our flow model? Anybody thinking that? We haven't looked at that in a while. Maybe we need to do something different. Now, big change, I think I mentioned this in my earlier talk, we're seeing a lot more ESI 2s and a lot less ESI 4s. We kind of sort of expected this would happen with urgent cares and, minute clinics and every other venue, that they would bleed the lower acuity patients off, and we're really seeing it. In some places, it's happening fast. Do you remember me showing you that table earlier today where literally in 3 years, they completely flipped? So how can we take the pressure off of those major care beds? Does everyone agree your beds are your prime real estate in your ER? You just don't, do you always feel like you wish you had more beds? Show of hands, or am I wrong about this? What do you think? Need more beds? Yeah, it just feels that way. So could we peel off some of the 2s and send them to the minor care area through the physician in triage? And the most likely group would be chest pain, which is by definition an ESI2, but young healthy. Could they just be a subset? So I want you to imagine patient streaming that gets more sophisticated. It starts with an ESI level, and then we layer different subpopulations on top of it. The goal being, can we take the places that have capacity, which anymore are often a fast track and a mid track, they have capacity. You don't have capacity where your beds are. And can we start to sort of tease some of those patients to some of these areas? And it's also with the knowledge that, oh my gosh, you can treat a lot of things in recliner. How many of you are doing some recliner care, true vertical model? Isn't what you thought you couldn't do? Anybody doing a chest pain in recliner? You could. I think you start to realize we always said, we can never rule out appendicitis in a recliner. Anybody doing that? Yeah, you actually, you find, wait, where did these rules come from? Because we're breaking them right and left, So in any case, we're going to get more sophisticated. And maybe at some point you won't even use ESI. You'll have sets of diagnoses, and probably you'll layer on age, right? Because as age goes up, so does acuity, and you'll stream that way. But for now, I find most are starting with an ESI and then layering different rules on top. And like I say, I worked with an ER just like last week that is doing appendicitis in the fast track. Hey, you can, it's your real estate. There's any number of ways you could do this. And so here's showing you, could we pull some vertical ESI 3s into the fast track? Because many of you have capacity in your fast track because all those ingrown toenails are not coming. The other thing is, though, for those of you, how many of you are at teaching hospitals? Can I see that? How are we going to train residents to do an ingrown toenail when they could go through a residency and not see one? I mean, we really are bleeding those low acuity. We have to think about that long and hard for training tomorrow's doctors. So could you pull some 3 special categories? Maybe you'll say, we're going to do some migraines, treat them without an IV. We have a protocol for migraine, and do them in our fast track. There's many ways that you could do this, and I want you to feel like you have full reign. And I have a number of sets of guidelines if anyone wants to email me, and I'll send you what I've got for different ways that you could do this. And then I'm actually about to do this with my favorite people in VCU because they're up for anything. Man, you've never met a group of people that just are, let's give it a try. And that's why I think they keep getting better and better. I would venture to say they may be the top performing academic ER in the country. And could we give you a little hand? Because door to doc, 11 minutes, and they hang on to it month after month, year after year. Anyway, they're willing to think about some finessing of these patient streams because they've got room in their fast track. They've got room in their mid track. It's their bed space that's so valuable to them. So when you're cleaning up your department, you're streaming rules and guidelines, exclusion criteria. By the way, it's a lot easier to write exclusion criteria than inclusion criteria. So as I say, you may want to say, old and on thinners, you don't go to the fast track. You may want to say pregnant abdominal pain, you don't go on mid track. I mean, you would decide how to do this. And then for every role in the department, I think we need to revisit standard work, because I'm still going places and I go, and who's responsible for collecting the urine? We all are. What does that mean? No one, right? No one's responsible. We all are. No one's responsible. And so re-educate everybody in your model. This is cleaning up house, cleaning your department. It's like your spring cleaning of your garage when you're at home, right? That's what we're trying to do with these things. All right, metric-driven management. We never run our department blind. We're always looking at data. Let's be honest here. How many data junkies are in the room? You are among friends. Data junkies, come on, I know I've got some, right? People who love this stuff, you wait for your reports. Oh, and I wanted to say about that tableau, it's a nice visual display that anyone can look at. Your hospital may have it. You know, we have clients that they don't know they've got it at the hospital. So if you are looking for a nice way to organize your ED data for operations, just find out from your hospital that they have a license for Tableau. You might already have it. All right, what do you need to look at and keep a track of for a well-run ED? Who's coming and when? And now, as I said to you, you know arrivals by day, by hour, you know census by day, by hour, and you know ESI by day and by hour. What does the data tell you? Are most of you staffing Monday, Tuesday through Friday, and weekends, or something of that sort? How many of you have different, you open zones differently on different days of the week, and you staff differently? Oh yeah, you need to, and you'll see some of this data here. Oh, by the way, this is showing you arrivals by hour, and I want you to know, all of you have a curve that is somewhat unique to you. If you have a lot of pediatric patients, then you may have a second bump in the evening when you finally get around to getting little junior to the ER with an earache. This looks like a geriatric curve to me because the arrivals fall off quick. When I have a lot of young college students, like UT San Antonio, their arrival curve stays till like midnight because them college kids are out hanging out and doing stuff, right? So you should know kind of what your pattern is, your daily arrival pattern. We said this, and I'm repeating again, your ESI arrivals by hour can tell you what zones you're going to open, what sort of geographic areas with what services, when you will open them and close them. I wanted to show you this because we're talking about Monday being different from Saturday, say. Look at this. You need a mid-track, which is yellow for middle acuity. You need that open by 9. Look at your green. Maybe you open your fast track at 10. This is Monday. Look at Saturday. Maybe we don't open the mid-track till noon. And oh, by the way, can we populate the fast track on the weekends? Probably not. So are we going to do something different? Will it morph into something different on the weekends? And I think you should think about your real estate. And, you know, I'm sorry, ERs, the space is too precious for anyone to be sitting around with empty spaces, right? I mean, we have to rethink what we're doing to not have that situation. Mentioned to you, and I'll say it again just in case it went by too fast, red curve arrivals. You open areas to arrivals and you staff areas to arrivals. Black curve is census, the number of bodies in the department. You close based on your census. The personal best for the most wicked situation is an ER. It was large academic that went down to 2 providers at night, leaving each attending 49 patients apiece. What do you think of that? They paired back, but their census was too high. And it was untenable, and you know that was a recipe for disaster. And this is showing you, again, Monday you don't have enough beds. There's your gray line. Saturday's a different beast. Saturday you have plenty of beds for what you need to do. Also notice that the Saturday curve is closer. Census to arrivals are almost on top of each other, showing more efficient functioning. All right, so the other things that we're going to do are your routine metrics. You're going to do those, and you might look by day and by hour. For instance, Monday looks a mess, doesn't it? Why is Wednesday like that? So do we need to look at Wednesday? This is length of stay by day of the week. Do we need to look at Wednesday and what's going on there? Do we need to look at Saturday? Have we peeled back the staffing too much? And here's just showing you, so if you want to come to an ER, you know you're going to probably come on Tuesday at about 8 a.m. if you want to get in and out the quickest. Look at the kind of variation. And so can you use this data to tell you how your department's functioning and what you need to change? All right, zone-specific data. I told you now, you got this data, man. Let's just milk it for what it's worth. And I'm going to show you some of the things that I look at when I'm looking at zones in an ER. I look at that ESI. Mind you, I want to see the fast track have something close to 4. I want to see a mid-track have close to 3. These are ESI, the mean ESI. I want to see a resuscitation probably be under 2. Does that make sense to you? You should see. So I'm working with an ER, and they've got like 5 different zones, and the acuity is sort of the same everywhere. I said, I don't think you're really streaming well, do you? And they're kind of nodding to me. Yeah, we could use a little help with that. So this is roughly what I'm looking for. Then I'm also looking at admission rate. And I'll say this, that fast track admission rate bothers me a little bit. Why would it bother me that they only admit 1.2% of their patients from the fast track? Could it be too tight, too selective? We're not letting enough people come to the fast track? I don't mind seeing a 5% admission rate from fast track, quite frankly. Your mid-track, 8%, what do you think about that? Only 8% of your patients being admitted from your mid-track? Again, maybe too tight? Should we look at that, especially if productivity is low in the area? So look at those. What you need to know is when you do proper streaming, your beds will have a higher acuity. Nurse leaders, do you need to change your ratio in your acute care areas if the admission rate approaches 40% and the acuity is higher? So think about it. On the other hand, if we do a good job streaming fast track and mid track, maybe we can back off. I know some mid tracks that are doing 5-to-1, even 6-to-1 nursing to patients in their mid track because they're not doing a lot of IVs and they're not doing a lot of intense nursing care. So I want you to look at this when you know if you're streaming well. Then I also look at that productivity. And like I say, I think that you can almost eyeball, but if anyone wants some guidelines, I tell you where I like to see things to judge whether the area is being productive. And I want somebody coming to work in a fast track to know they'd like me to see 18 patients a day or so. Don't you think that it's good for people to come to work with an expectation of what they're going to be doing? And we've kept it very loose in the past. I'm happy with the fact that we've taken some pressure off of the acute care beds here. Notice that about 29% are going to those acute care beds, versus I showed you another breakdown where almost 40% went to those acute care beds. And then I'm looking at efficiency by zone, door to doc and length of stay. These door to docs are just excellent. Everyone is getting seen very quickly in a timely fashion. And the length of stay, maybe fast track could be a little bit faster, but this isn't bad at all. This looks good to me. I do want patients, if you do a physician in triage, you should be striving to discharge some patients from triage. There are patients that just need a kiss goodbye, right? There are some people who just need a kiss goodbye, some reassurance, and that's what you should be doing. All right, my last little bit. There is a treasure chest in your department right now of physicians, and actually there are nursing behaviors too, where I'm sure you could name off the top of your head, if you're a physician, the physician in your group, if you're a nurse, your nurses, who are efficient, deliver timely care, they just are doing such a good job, and if you've got a bad patient and they're assigned to it, you feel good about it, right? So what I want you to start doing is trying to identify, oh, by the way, let's do it in a public way. Let's reward the people that are doing a good job, and let's tease out of them, how are you doing this? Kurt, you see more patients than anybody, and you see them faster. Show me your workflow. And I really believe that this is there. The other thing I was going to tell you is there's top performers, but guess what else we're seeing? As we do more streaming, not everybody is good in every role. The case in point is physician in triage. There are some docs that just rock it, right? Would you agree, those of you that are doing physician triage, some docs are really, really good. They were born to do it. And there are other doctors, when they're out there, you go, oi, right? So we need to identify, and I think people are accepting that some doctors excel in other areas. And so why not put people where they do well and they excel? It's an idea. Should the physicians in triage who are really good at it be incentivized to work those shifts? Should we do it for night shifts? So there's a paradigm for it, right? Anybody ever tell a doctor who wanted to work nights they couldn't? Same thing, nurses ever tell a nurse who wants to work nights? No, you can't. So I think we should allow those people, but it's very clear that people that are good in one area may not be good in another area. What's stunning to me is the doctors that have been the most productive in acute care often just flounder out in triage. It's really interesting. I had one older doctor say to me he loved physician triage because he was tired. And he said, when I'm in the back, I'm running around, I might have to put a chest tube, run a code. I'm old, I don't mind just sitting out there in front and saying, go, stay, here, you go there. And he really liked it. It had given him an extra few years in practice to be a physician in triage. So in any case, I want you to identify top performers, acknowledge them, and tease out of them what are they doing. Sometimes it's workflow that has to do with the EMR. Sometimes it's just the sequencing of how they do things in their workflow that's helpful. Same thing with nurses. By the way, if you take on the patient flow facilitator, so I would say this, the pivotal position in an emergency department with most of the flow we've seen is the physician in triage. The pivotal nurse role is that patient flow facilitator, especially the front. The back too, but the front. And those roles, some nurses, it's funny, we run rapid cycle tests, and some nurses there, I say, she's spinning because her head's spinning like this, it's too much for her. And then others that just seem like they were born to do the job. They just can keep a finger on the pulse of the whole department and feed it properly. So, recapping my strategies, engaged leadership, that would be you, always messaging that patient flow and efficiency and so forth is important to you. Clean up your department, and I think I told you how, and you've got the notes there in your book. Then what are the metrics that are going to drive you and help you constantly keep a finger on the department? Is it running well? I think you can set, and mind you, I think it should be reset every year. What are our goals for each zone, both time and productivity goals? Let's set those for ourselves. Because you want to know what? If you set them, you will get there. It's stunning to me how often I've done that, where they set the goals and they make it, and then they can reset it. And then your copycat behaviors, tune into the docs and nurses that are very good at their jobs and glean from them what you can. And that's all I have. Any questions? Yeah. So what you counter is the liability in the waiting room and the patients that leave without being seen. That should be considered to be riskier business than having your name on a chart. Plus, can I tell you, it's really kind of embarrassing. But what do doctors say when you want them to do something they don't want to do it? Liability, right? Oh, liability. And do you know these numbers that you don't live in Pennsylvania, do you? Okay, Pennsylvania may be a case unto its own, but it's 1 in every 20,000 patients, visits, may start into some sort of a legal situation, and then it goes down from there. So the risk is so much smaller than what you think. Now that said, anyone that's ever gone through a liability thing, you're like, thank you very much, don't want to do that again. But I would say this, so something happens to somebody out in the waiting room, or they leave, like I know a whole department that's sued because someone was not seen in a timely manner, they left. They were there, by the way, 3 times asking for help for a drug problem. The 3rd time they left, they were found dead 3 blocks from the hospital. The family is very affluent, and the whole department hospital system is being sued. So it's risky, and I would just say you're going to find that it's just such better care on every other front. But really good question. I know you worry about that. Yeah. Actually, I've not seen that. That would be a great study. I've not seen it. And does anybody in the room know that? I mean, the people in the USAC system, you probably do it the most. I don't know if there is something out there that looks at, does it improve the liability situation? Yeah. I'm so sorry I can't make that case for it. I can make just about every other case. I can make a financial case for you for physician triage if anybody wants to see that. I can make all kinds of, or you'll pick up sepsis sooner. You'll have less walkaways, less elopements. I can make every other case but that one. So sorry. Yeah. See, I have to confess, I believe there's enough literature to suggest that the highest level of training person should be doing the physician in triage. How does it work with nursing? Oh my gosh, can I tell you? So to say you're doing physician in triage is to say virtually nothing, because there's about 20 things you would have to decide in terms of your version. So I've seen it be a greeter screener nurse that just a very quick intake, and then they go to the physician. I've seen the team swarm and do it in physician in triage. I've seen a very abbreviated traditional triage, but then quick to the doctor. I mean, there's so many ways that you can do it. Then, oh my gosh, do we give meds or not? Do we start IVs or not? There's so many questions. So to say you're doing physician in triage, my cute little diagram, it really ain't that simple, because there's so many manifestations of what that could look like. And every time that I've thought that I knew better, a client has shown me that they actually had a way that was slightly different but also worked. So, but I like anything that gets the whole team involved earlier, in my view, is a better model. And oh my gosh, guess what? If they only have to tell the story once, what a lovely thing from the patient's perspective. Yeah. Yeah? So, yeah. So, and that's a great question. It probably deserves a topic unto itself. But I have seen both extremes. In fact, I've got a group that they've been doing physician triage. They're a very sophisticated group. They've decided, you know what? We're not doing any documentation up front. We'll have a triage, the nurse's triage note, and then we're going to go to the back, no documentation. I've got another client, in fact, Brown University, Rhode Island Hospital, they have scribes on steroids. They document the entire encounter up until where the results and medical decision making in triage with their scribes. So again, we were saying there's all different ways that you could do this. Thank goodness the EMRs, which did not have this a few years ago, most of them have the shared note option, which is a very nice way if somebody wants to document just the part of the history they got and pass it off, and another provider's going to catch in the back and wrap it up. Mind you, I like all of the models where the patient's seen by a physician, it's a shared encounter, and they're caught in the back, as opposed to when you try to do it from the front, with the exception of you've got a lot of low acuity and you want to do a rapid treatment unit, and that doctor just does everything start to finish. In most cases, most threes, they're going to need some testing and treatment and so forth. So seen by a provider and passed off. And I've got to get off the stage because I'm cutting into his time. But you know what? We can talk more about this if you want to in the open forum. Some of the nuances and subtleties about this, because there's a lot to explore.